Hi, so just imagine that we've got a patient at home and we want to gain a bit more information about their fluid status. So what I'm going to do is I'm going to use the ultrasound probe to scan the patients and gain some more information about how wet their lungs might be, how much intravascular volume the patient has, and if the patient is in any, renal obstruction. So, got my butterfly probe here and a bit of gel, and we've got my patient here sat in the comfort of their own home. And the first thing I'm going to do is I'm going to scan the lungs.
And as we place the probe on the patient's chest wall anteriorly, the first thing that we should see is that there's a lot of horizontal white lines, and these are called A lines, and they are normal and found in normal aerated lung. And what they represent is essentially an artifactual repetition of the pleura. So the ultrasound waves hit the first white thick line at the top, that's the pleura, and because the lung is aerated and ultrasound doesn't go through air very well, the ultrasound waves just bounce backwards and forwards and create lots of A lines. Now, the moment there's increased lung water, the ultrasound waves now find something to bounce around in and create these vertical lines called B lines. So compare these B lines on the left here compared to the A lines on the right. Now we've scanned the patient anteriorly, and now we can have a look laterally, posterolaterally, to see what the interface between the lung and the diaphragm looks like. And in the example that we've got here, that's a normal lung. So on the right here, this darker organ that we see coming in, that's the liver. And as the patient takes a deep breath in, you can see those A lines and that lung curtain full of air just coming in and just obliterating the view of the liver. Now compare that to someone who's got an effusion, such as the patient here on the left. You can still see the diaphragm, which is the bright white line, and the spleen, which is that dark grey organ, but there's a lot of black fluid accumulating above the diaphragm, and that's a pleural effusion, and you can see a bit of the collapsed lung as well.
So we've already seen how we can use the ultrasound to look at the lung, but Cam, just show us a bit more about how we might examine how the heart's functioning.
So what we can do with the same probe is again examine the patient's heart and have a look just visually with our eyes without doing any fancy measurements. Does it look overall okay, or does it look really impaired? So we're going to put the probe in a cardiac setting, and we're going to scan the patient, and I'm just going to capture just 2 or 3 views, which should give me sufficient information. So straight away, I've got a good view here of the patient's myocardium. I can see the left ventricle just on the left there beating nicely. You can see that the right ventricle just at the top is not enlarged, so already I'm getting some good information that the patient doesn't have severely impaired LV function, it's not severely dilated, and there's no pericardial effusion. Just one quick maneuver with my probe, and I'm looking at the heart in kind of the short axis now, and that's a really nice view just to look at the LV overall. You can see everything just contracting nicely. The RV at the top left there is not bigger than the LV, and there's no kind of bowing of the septum into the LV, which would be suggestive of, say, a PE in the right context. So I had two good views there. Just have another view if I can from here. So this is what we call as the apical foreview chamber. So just to orientate you, the probe at the top is at the patient's apex. So the left ventricle is the one on the right, on the top right. The right ventricle is the one on the top left, and the atria are the ones corresponding to beneath them. And here we can see that again everything seems to be working just fine. That the dimension of the RV isn't bigger or isn't approaching the size of the LV. So there's no right-sided kind of dilatation. The LV is functioning just fine. So we've got 3 good quick views. Just lay flat for me, and then we can just finish it off by looking at the subcostal view again, and that's again just to confirm everything that we've seen. You can see that this is the patient's liver coming into view, and as I just flatten the probe, I can see the cardiac silhouette come in, and already I'm getting some good information. The heart's beating nicely, it's not severely impaired. And what I'm going to do is I'm going to bring that IVC right into view by slightly rotating my probe.
So you just moved your wrist a bit to rotate.
Yeah, so we were here looking at the heart. Yeah. I'm going to get the right atrium in place, and I'm going to rotate just gently until that black
IVC, so that black IVC coming into view. There it is. And what I can see is that I can look at the size of it, so it's approximately 1 centimeter in AJ. And as he takes normal breaths in and out, you can see that the IVC collapses quite fully there.
And if it collapses, what does that suggest?
Well, if it collapses more than 50% on passive inspiration, it suggests that the patient is likely to tolerate safely more filling. And so it can really help us with someone who's hypotensive and we aren't really sure whether we should be given more fluids or not.
So another common situation we call is a patient who says they haven't been peeing. And of course, one of the questions we're worried about is, well, is it because there's obstruction or is it because in fact the patient's really dry? So Karen, talk us through how POCUS can help us in this situation.
So again, POCUS can be extremely helpful in this situation. So using my butterfly probe, again I'm on an abdominal preset. I'm going to have a look at the bladder, see if it's grossly distended, if there's any fluid in it at all, and then have a look at the kidneys as well. And so first thing I'll do, I'll just place the probe on the patient's suprapubic zone and just angling it down. I can see that the patient's bladder is there. So first of all, we can tell that the patient is producing fluid, and we could measure it and see how much fluid there is. And we just have to take a couple of views, but it doesn't look overtly distended at this stage. So having a look at the patient's bladder. We can have a look in 2 different views. And then using those 2 views, I can then take 3 measurements, multiply them together, multiply it by half, and you get an estimated volume, much like a bladder scan. But now, next question is the patient obstructed? See if the bladder looked a lot bigger, and I wanted to exclude hydronephrosis, especially if the patient was in AKI. Next thing I can do is have a look at the patient's kidneys. So would you mind just turning over to one side and say thank you? A bit more gel. And again, using the same scanner.
And how are you judging where you're going to start placing it?
Well, usually just in the patient's flank. Every patient's a bit different in that respect. But kidneys are usually on either flank, and you can kind of move the probe around until you get the best view. It just takes a little bit of practice, but most patients you'll be able to find it just fine. So, just looking at the kidney here, Ada, if you could take a deep breath for me. You can see the outline of the kidney just appearing, and I'm just fanning through the whole kidney. What I can see is that the cortex, the medulla, and the calyces all look normal. There's not a huge amount of distended, black, fluid-filled calyces, which you'd expect with hydronephrosis.
It's a good reminder that the kidneys move with respiration.
That's right, and you can actually use that to your advantage. You can get the patient to take a deep breath, everything moves lower down. Right, so there it is. Perfect view of the kidney. We're fanning through it, there's no obstruction at all. And I can do the same on both sides. But there, very quickly, we've had a look at the bladder. We know that urine is being produced, but there's no obstruction. The kidneys don't look hydronephrotic.